Okay, another very important point. There are a lot of people who thinks that I'll be seeing the recording only. Yes, definitely. We'll be providing the recording and you can check the see the recording also. But it is not a replacement of the live class, because in live class there will be interaction. You will be able to ask any questions you have. If you are not able to understand, you ask us to repeat any or demonstrate once more. So that is the advantage of joining live. And another very important thing is what I was telling. First, you have to open the app. You have to go under the batches tab. Okay, and under the batches tab, you will be finding that there are few important tabs like overview, the most important highlighted portions. Okay, say it may be a test or something that is given, it will be shown in the overview section. Okay, so it is just a summary of everything, so you can ignore that. Next is the announcement. In the announcement you will be getting two things. Once we want to announce anything to you, will be putting in the announcement section, as well as your class links, daily class links will be posted in the announcement section. Okay, so next thing is the test. Now this tab is showing empty to you right now, but once we launch the test, it will be here. And one thing is very important, that these tests have time expiry. That means if the test is started today, it will expire just before your next class, and in the next class we will be announcing the name of the toppers. Okay, so go with the class. Even you are not able to see the live class, you see the recording, and after seeing the recording complete the test. Okay, because this happens every time. A few of the candidates, they miss those tests, and in future they ask to give us the test. But remember, it's a group event. Okay, we can give the test to all, not any single candidate. Okay, so afterwards definitely we have part evaluation where the similar questions, and some questions will be same, will be asked, so they can go for the part evaluation questions again, but they will not be able to get these questions afterwards. Okay, so within this 7-day time period you can take the tests any number of times. Sound is all right from our side.
This is I have written, so I
Okay,
think
okay,
now
fine.
now it's okay. Mm.
And that is the test portion. Okay, and after completing the test, after each evaluation, you will be getting the detailed explanation of the questions. Okay, there will be not only the answers, but will be the detailed explanations what should be the correct answer. Next we have the videos section. Here you will get the videos, mainly the class recordings or some additional videos that we want to give you, that will be within the video section. You can open it and you can view it anywhere. Okay, it is highly mobile optimized section, so you can see this anytime with your app. So you do not have any time limit. Even if you are busy in OT or somewhere where you are getting time, you can study. Okay, so that is the most important thing regarding the everything. Whatever we made, they are all optimized mainly for the mobile use. Okay, so that anytime you can read the study material. The problem is, some of you asked that whether this study material can be printed or not. Definitely they can be printed, but as they are optimized for the mobile, usually their types are very large. Okay, so in printing, one study material will require maybe hundreds of pages. So you just go into the third tab, that is the study material tab. There will be, after every class we will be getting the study materials. Okay, some important questionnaires, some important ISSP materials, they are there. So if you want a PDF copy of this ISSP study materials, ISSP stands for the Indian Society for the Study of Pain. So it is the umbrella association. They provides the guidelines and links, and these ISSP guidelines, they are also present in the ISSP website as well. So if someone requires these specific things, okay, for example the ISSP guidelines, so that they can take from the ISSP website as well. Okay, and here there will be another folder where the class-based study materials will also be posted. So you have to open and you can check the study material. So I think you can understand this app quite well, and there will not be any problem using the app. That is the most important thing. And apart from this, there will be the WhatsApp group. I think every one of you have joined from WhatsApp group. So we'll be putting you the links as well as important things in the WhatsApp as well. But you should check both. Okay. So I think that's all.
Okay, let us start today's class now. Acha, one thing is everyone should remain muted, otherwise it will be a disturbance. So whenever I will ask question, then you just unmute yourself and tell the answer, and then again you mute yourself. Okay.
Just 1 second. I am requesting Dr. Tejas Nayak to please check your speaker because we are able to hear it clearly. We are in a different place. So there is no problem within the microphone of us. So there might be a problem in your speaker. Whatever device you are using, it's maybe a laptop or maybe a mobile. In the speaker, there might be any problem. So you just check it. Another important thing is that someone wants to access the videos in a laptop. So there, as our app is mainly based on the Android and the iOS, so there is no direct way, but I will be giving you another way using one software that is known as the BlueStacks. By using BlueStacks, you can see that in your Windows laptop only. Okay, the Intel based laptops also support any Intel based laptop, basically not only Windows. Okay, Intel based Mac also supports, but only the M1 chips on M2 chips that will not be supported. Okay, there is also solution, but they are not free solutions anyway. Okay, let's continue.
Yeah, so today's class is actually the initial introduction class, you can say. So, but too many topics are there. So, few topics. So, I will just tell you in brief, not the whole thing. So, you after listening to these topics, you please read the study materials, and we will other topics we will put the videos in the app. So, please see the videos also. Okay, so this initial part you have to be this will make the concrete understanding. You have to make the concrete understanding to understand the later classes, because this is the starting point. Okay, so anatomy, physiology, pharmacology, and some clinical general approach towards pain patient. Okay, so let us talk about the anatomy first. So when you are hurt, then what happens? So some pain impulses that are started in the periphery, they travel from the periphery towards the brain. So from this is recapitulation of our physiology knowledge. Okay, so peripheral transmission up to the spinal cord, from periphery to spinal cord, this is the peripheral transmission. And central transmission means spinal cord to brain. So we can also divide in first order neuron, second order neuron, and third order neuron. Second order and third order together forms the central transmission. First order neuron, that forms the peripheral transmission. Okay, second order means it is up to the spinal cord to thalamus, and from thalamus to cortex, that is the third order neuron. Okay, so nerve fibers. So here you can see. So okay, so here, so this is also anatomy part. So nerve fiber, there are multiple types of nerve fibers in our body. Okay, unipolar, pseudo unipolar, bipolar, multipolar, multiple types are there. Most commonly, the sensory neurons are pseudo unipolar. So what are the parts of a neuron? So this is the cell body, and then presynaptic terminal and receptor terminal is there. From one side, the this signals, the action potential starts, and from one side the impulses come and it flows to another side to the synapse, into the when it makes the second synaptic junction with the second order neuron. Okay, so as when we are talking about the nerve fibers, then there are multiple types of nerve fibers, A, B, C. Mostly it is from thick to thin. Okay, A is the thickest, then comes, what is happening? Okay, so uh, okay, so A is the thickest and C is the thinnest. A also have multiple type, alpha, beta, gamma, delta. So that is also from thick to thin. So multiple types of fibers are there, and all types of fiber are not associated with pain transmission. We are mainly we are mainly uh, since we are talking about pain transmission, so we are mainly interested in A beta fiber and A delta fiber and C fiber. These two fibers, only A delta fiber and C fiber, is actually associated with pain transmission. Then what is the A beta fiber's role? A beta fiber, just we are saying about mentioning this A beta fiber here, because this is presence of A beta fiber actually gives us the correct sensation of pain. Otherwise, the sensation of pain in somehow it detects, it depends on the function of A beta fiber. And also this A beta fiber has been used as a for doing some treatment. So for doing some neuromodulation treatment, we need to stimulate the A beta fiber. So ultimately, for a pain physician, anatomically, we need A beta fiber, A delta fiber, and C fiber. A delta fiber, since it is thicker fiber than thinner fiber C fiber, that means it will have a faster transmission. So you can just remember around 20 meter per second. It is the transmission rate, and C fiber 2 meter per second, 220, just in that way. So A beta fiber is a fiber who has faster transmission. C fiber is a slower transmission. So immediate pain, what we feel, that is the first pain. So that is transmitted by A delta fiber. Slow pain is transmitted by C fiber. Now, some other thing is nerve fiber. What are the structurally how it is formed? So centrally it is the action. Then comes myelin sheet. It may be present, may not be present, but it's action. Then outside myelin sheet. Then three layers: endoneurium, perineurium, epineurium. So just remember that, because when the nerve is damaged, then damaged, how much it is damaged. So that will depend on which layers are gone, which layers are destroyed, and which layers are still intact. So these layers we should know. Now, as I told you, first order neuron, when they come from periphery and to spinal cord. So where they come to the spinal cord? So these are the rexed laminas. There are 10 rexed laminas. So mainly 1, 2, 3, 4, 5, this much is important for us for pain transmission. 3 is important. Why? 3 is important for interneurons. These lamina is for interneuron. What interneuron does, that we will tell later. Anatomically, this 3 lamina is related to interneuron. And otherwise, spinothalamic tract that forms for second order neuron, that is related to lamina number 1 and 5. Now, let us talk about, so we understood anatomically that first order neuron comes up to the rex lamina, that is the spine, up to the dorsal horn. Okay, so from there second order neuron starts. So how it goes, which second order neuron, what it forms? So it forms different type of tracts. You can see dorsal column is there, spinothalamic tract is there, spinocerebellar tract is there. So name suggests spinothalamic, means spine to thalamus. Okay, and these columns, we know that, okay, these columns are there and it carries vibration, conscious proprioception, 2-point discrimination, etc. So it is not related to pain, but still we need to know that dorsal column carries vibration, because it has been used as a treatment purpose of pain. So just for remembering, spinothalamic tract, now this is the most important tract for pain transmission made by the second order neuron. Okay, so lateral and anterior, two types of spinothalamic tracts are there. Okay, so it ultimately transmits the pain and temperature, crude touch, all these things, sensations. Okay, so it is the main tract. There are some other tracts which are related to some phenomena which are associated with pain, like spinomesencephalic tract, spinotactile tract, spinoreticular tract. So what are the associated symptoms with pain? So if pain occurs as soon as there is a postural readjustment, immediately we see that where in our body is paining, and then we may feel depressed, we may cry. So that is also something. Then in our body, there is a system that automatically pain suppression starts as soon as pain goes towards the brain. So at the spinal cord level or in the brain level also, pain suppression also starts. So these tracts have their own uh, actions, like spinothalamic tract transmits pain. Spinomesencephalic means spine to mesencephalon, it has its own action, that pain suppression. It has this it will, this area mesencephalon will act as a pain suppressing tracts will form from there. Okay, so in role in pain suppression. Then spinotactile, so you can see that reflective eye and head movements towards site of painful stimuli. So this is coming from this one. And then spinoreticular attention to painful stimuli. Then spinocerebellar tract. Here also unconscious proprioceptive information it transmits. So these are also for related other areas of when a pain occurs. So some other things also occur. So those are taken care of by these tracts. Now pain has reached up to the thalamus. Now it will go up to the brain. So that is the third order neuron. Brain means cortex. Okay, so third order neuron from thalamus to cortex. Now it directly doesn't go to from thalamus to cortex. You can see from this is the thalamus area. Okay, from thalamus it is going to S2 and then it is going to S1 also. So these are primarily Brodmann's area sensory cortexes. Okay, S1 S2 primary S1 cortex or S2 cortex. So this is one way how the pain impulses are traveling, but it has some another path also. What is that? So from thalamus you can see anterior cingulate cortex, prefrontal cortex, insula, amygdala, basal ganglia. So these are also stimulated. There are some fibers which are going from thalamus to these areas also. So remember, all these areas are important for pain transmission anatomically. We are talking about anatomy. Okay, so this somatosensory cortex S1 and S2 is important, and this side is also important. So just for MCQ question, you can say that anterior cingulate cortex, prefrontal cortex, insula, amygdala. So these are important areas where emotional component of pain actually from these areas, emotional component of these are important for emotional component of pain. Another thing, from here you can see all the feedbacks are coming to PAG, means periaqueductal gray matter. So PAG is a area, means periaqueductal gray matter is an area from where the normal inhibitory neurons start. Of course, it has some its own other areas also which help it for starting of the stimulation of inhibitory impulses. Okay, that is rostral, ventral, medulla. Anyway, so periaqueductal gray matter is the main anatomical area from where the inhibitory impulses start working, inhibitory pathways start working. Okay, pain matrix, it is not very important. By functional MRI it has been identified that which areas are important for pain transmission. Now, as I told you, that descending pain inhibitory modulation system. So normally in our body, there is a system which tries to dampen the pain, so that one patient, one person is hurt, after some time pain is a bit decreased. So this decrease has been done naturally by our body. Otherwise, he will go on crying and crying and shouting and shouting. So as I told you, that ultimately this area, PAG area, it is getting there some feedback from other areas to PAG area. So now this PAG area, this is the periaqueductal gray matter. This is found in midbrain. Okay, some other areas are also his friend. So the pons has this one locus coeruleus, medulla has this nucleus raffimagnus. So these all areas, okay, periaqueductal gray matter along with nucleus raffimagnus or the locus coeruleus. So ultimately all are in brainstem. They are the starting point of descending inhibitory pathways. Okay, as we have talked about the somatosensory system, how a person when he is hurt, that how the impulse will start from periphery and go up to the brain. Okay, so this much you have understood. First order means up to spinal cord, second order means spinal cord to thalamus, third order means spinal cord thalamus to cortex. This is in two parts. Okay, now and of course pericortical gray matter is the main area from where the descending inhibitory inhibition, anatomically this is the area where from it starts. Okay, now this is the somatosensory system. Sympathetic system is also important for many different types of pain. It is not that when we get hurt on the skin or bone, then only we get pain. So we can get pain from viscera also. So viscera is not supplied by the somatosensory system, that is supplied by the autonomic system or sympathetic system. Now mainly the sympathetic system which is important for many types of pain. So here in sympathetic system, it is remember there are only two types of so this is motor system and sensory system of sympathetic system are fibers are mostly going together, but there is only some differences there, that I will, 2 points are there I will tell. But think about this motor system which are very common in all books, this type of picture. Sensory system picture is not there. It is very difficult to find. But then sympathetic system, so here two parts are there. As in somatic system I told you that peripheral systems, central system or first order, second order. So here there are only two part. One is preganglionic neuron and one is postganglionic neuron. So these are ganglions, these are ganglion areas. Preganglionic, these red colored neurons are preganglionic neuron, blue colored neurons are postganglionic neurons, and this starts from the lateral horn. Here preganglionic neurons we also call them white remi communicantes, and then blue as gray remi communicantes. Why it is white remi? White means it is myelinated. When the nerve fibers are closer to spinal cord, then myelination is there present, and myelination present means it becomes white. You can remember in this way that these are white remi communicantes near to the spinal cord, and distance from the spinal cord, then it is not myelinated, so gray remi communicantes. Otherwise preganglionic, postganglionic. And then it has three fates. When it comes to the ganglion, either it can synapse here, or it can go up and down, or it can go through and through and synapse at a distant area. So these three fates are there. Okay, but these autonomic system, this is mainly responsible, many times responsible for visceral pain and even chronic visceral pain. So this sympathetic system becomes important for diagnosis and treatment both, of course. So anatomically we can find all the sympathetic ganglions, we can find those which are important in the sympathetic system, and we know that from T1 to L2, that is the area where the motor sympathetic system, this is the your extension. But as I told you that sensory system mostly follows the motor system. Only in 2 points they differ. How? They will not go up and down. Okay, they will go straight. They will go straight at the same level. That's why sensory or sympathetic system, that is not expanding from T1 to L2. That is expanding from C1 to CO, coccygeal 5 or coccygeal 3. So in all level sensory is there, but this motor part of sympathetic system is only from T1 to L2. But this is also required for anatomically. I talked about that. Cranial nerves which are important: trigeminal, facial, glossopharyngeal, vagus. All these nerves carry the sensation of pain. Now only trigeminal neuralgia or trigeminal pain is very much common to us. So I will talk about only trigeminal. Remember anatomically, as first order neuron I told you that periphery to it has similarity, similarity to with the somatic system, that it also starts from periphery, like means facial skin. From skin the first order neuron starts, and ultimately it goes to the pons. to the pons area, means trigeminal nucleus, nucleus. It enters in the pons area and then comes down up to the medulla. That is the trigeminal nucleus. So it comes up to the spinal trigeminal nucleus. That is the first order neuron. Then spinal trigeminal nucleus, from there it crosses like spinothalamic tract, and it makes the trigeminothalamic tract. So it also enters again. It goes up to the thalamus. So that is second order neuron from thalamus to sensory cortex. So that is the third order neuron. And trigeminal ganglion, it is like the dorsal root ganglion in the somatic system. So this is also our target for treatment in many trigeminal neuralgia cases. Okay. So anatomy, we have understood this much. So now I will talk about the physiology. Remember, in physiology, the areas which I have talked in anatomy, in physiology also it has multiple correlations. I mean, you will find how these anatomical areas are important in which type of functions in physiology. So what we will learn in physiology, first is definition of pain, IASP terminologies related to pain, pain pathways, classification of pain, and peripheral and central sensitization. So this much you can understand. What is sensitization, that I will tell later. Okay. Definition of pain. So IASP has given a definition. So IASP is the biggest organization, you can say, in whole over the world in pain medicine, though there are some other organizations also. So we mostly follow the IASP, and their this definition has been accepted by all. So what is important here, that this is not only what is pain. We all know what is pain, but still few important things are there, like emotional component also been accepted as the in definition of pain. Okay, then experience associated with or resembling that associated with. So it is if patient is saying that I am in pain, you have to accept an actual or potential tissue damage. So you may see the tissue damage, may not be see the tissue damage. So these all parts are there in definition of pain. So 6 key notes, this will tell you that what are the notes. So pain is always a personal experience. So since it is a personal experience, if patient is saying to you that I am in pain, you have to accept whether you find anything externally or you don't find. Then pain and nociception are different. Okay, so this is also, I will tell you later, the pain and nociception are different. Nociception is a phenomena which we can see under microscope, or we have some, say, blood parameters to say that okay, this in this patient nociception has occurred. But pain is not nociception. This can happen that nociception has occurred, pain is not there, and there is no nociception but still pain is there. So both the things can be there. And through their life experiences, individuals learn to concept of pain. So ultimately it is individual experience. So okay, verbal description is only the several behaviors to express the pain. It is, of course, I mean, applicable. You know that if someone is not in a normal IQ level, so then also he may have pain. If someone is psychiatric patient, then also he may have pain. So 3 responses when your skills say there is an injury. So there are 3 responses usually: startle response, autonomic response, behavioral response. So startle response, postural readjustment and orientation of head and eyes to examine the damaged area. So you remember, that's I told you, apart from spinothalamic tract, there are some other tracts also like spinotactile tract, spinomesencephalic tract, and spino-reticular tract. So these tracts are giving this phenomena, responsible for this startle response. Then an autonomic phenomena. So these are also noradrenaline and adrenaline release. So that will also happen without your permission. So this is also happens while the 3 responses and behavioral response. So whether you will cry or not, whether you will rub that area or not, so that is also coming from one tract. So that is another response. Pain terms, there are multiple terms. I'm not going to explain all the terms here. You can find, this is the terminology page of IASP, so you can understand, you please read all the terminologies. You should know, whenever you are practicing pain, you should know all the terms. I'm talking about few terms only, like analgesia, absence of pain. we all know. So any child which is born with a congenital analgesia, he cannot live live long, he will die. So ultimately pain is a important thing for our living. Pain has some beneficial effect in normal life, otherwise we cannot live. So it tells us that when our body is somehow damaged in somewhere. Allodynia, pain, here just remember what is allodynia. Something which should not cause pain is causing you pain, like light touch, vibration, that is causing you pain, allodynia. Hyperalgesia means small amount of pain you have given, but patient is jumping with pain, like say a patient of fibromyalgia, you will pinch there, patient will scream. So that is called hyperalgesia. Allodynia is mostly seen in post-herpetic neuralgia cases. So even a touch with their own cloth can cause pain. Anesthesia dolorosa, pain in an area or region which is anesthetic, like it happens most of the time, many times it happens after treatment of with radio frequency for a trigeminal neuralgia cases. So we see that if you touch, just touch or pinch or pinprick, there is no sensation, but still patient will say that my this area is paining. So this is the complication, anesthesia dolorosa can happen in this type of area. So that becomes a central pain, whatever. So dysesthesia, another, so anesthesia dolorosa understood, the meaning you have understood. Then dysesthesia and paresthesia are similar. It is a tingling type of sensation or a say unpleasant sensation, but where it differs, paresthesia is not considered to be unpleasant, but dysesthesia is considered to be unpleasant. Okay. So here you can read all these things later. So here other few important thing: interdisciplinary treatment, multidisciplinary treatment, and multi-model treatment. Interdisciplinary means many doctors from many disciplines, they are seeing and producing one prescription. That is the best, but that is very difficult to achieve in different hospitals. So multidisciplinary means different doctors are seeing a patient and producing different prescription, but for the same patient different doctors are seeing. So that is multidisciplinary. Multi-model means all types of treatment is welcome when they are producing synergistic effect. So that is the multi-model treatment. Okay. So this also you remember, because later this is I will talk when I will tell the pharmacology part, then I will say that this is the multidisciplinary and multimodal treatment is the treatment what is our choice of treatment. Let us talk about common pain. What is common pain then? Common pain means good pain or physiological pain or nociceptive pain. Why I am saying this is good pain? Because this pain makes us I mean, this is for our own good. This is normally what we have. If you have a fractured leg, there is pain, so it is for your own good. So this is good pain or physiological pain. So first we will talk about this good pain. Okay. Nociceptive pain or physiological pain. Okay. So nociceptive pain pathway. So anatomically I have told you that first order, second order, third order neuron. Physiologically, transduction, transmission, modulation, perception. So what is transduction? These four parts you must just remember the names: transduction, transmission, modulation, perception. So what is transduction? Transduction, remember, when there is a peripheral injury, tissue injury, then inflammation occurs, mediators are released, and there is a chemical reaction. So these chemical reactions, when this chemical reaction occurs, then there is a action potential which starts at the nociceptor level. Nociceptors are found at the peripheral I mean, periphery of the first order neuron. Nociceptors are actually receptors in the first order neuron periphery. So ultimately, nociceptors are activated and action potentials are started there. Okay. So ultimately, what we see, that chemical reaction that is causing the electrical activity to start. So this much is transduction. Okay. Chemical activity to electrical activity, that is transduction. Then comes transmission. So electrical activity flowing now from first order to second order to third order, that is called transmission. Okay. What is modulation? As I told you, our body has a unique capability or its own wish that it will gradually try to decrease your pain. So that is happening through different pathways. I already told you anatomically it starts from the periaqueductal gray matter, so that one is modulation. Okay, now this is the third part, modulation. Somebody is actually, you should not do like that, because your name is also there. We can see that who is doing and not. Anyway, so okay. Yeah, transmission and so transduction, transmission, and modulation. So modulation means you can increase the pain, you can decrease the pain also. Our body can decrease the pain. Normally it decreases when we are talking about the good pain. So normally it tries to decrease. That is the modulation part. Okay. Then comes perception. So perception means from thalamus to cortex. This is also transmission, but perception means it is the, as I told you, that some part goes to the cortex and some part goes to the prefrontal cortex and some other areas in the front, in two areas. So perception means it is not only the somatosensory perception, it is the somatosensory part and emotional part both together. Then we will say that is the perception part. So you understood. So transduction means stimuli goes, this stimuli means it may be chemical, thermal, whatever, electrical. So this mechanical part, this mechanical part starting of the action potential at the nociceptor level, so that we will say that transduction has occurred. So what happens actually at the site of injury, mechanical, when we talk about the chemical reaction, then actually substance P, CGRP, nerve growth factor. So these cytokines are released there, and this causes inflammation, and ultimately that is the reason for action potential. So remember these things: substance P, CGRP, nerve growth factor, all these things are there. So these will also have a relation later. So this is transduction. Then transmission. For transmission, three things are important: neurotransmitter, receptor, and ion channel. So remember, so what happens? So these are the receptor area, and neurotransmitter comes and joins to the, so these are neurotransmitter. Okay, acetylcholine, others are there. So this is the neurotransmitter comes and joins with the receptor. As soon as it joins with the receptor, it fits there, and then ion channel opens. As soon as ion channel opens, mainly calcium and sodium channel ions, this calcium and sodium ions mainly, they enter from the presynaptic to they enter intracellularly, from extracellular to intracellularly they enter, and due to their entering, ultimately action potential propagates. So you understand that in transmission, three things are important: transmitter, receptor, ion channel. And then ion, mainly calcium, sodium. Whenever there is a inhibitory effect, then it is actually the negative ion which is actually goes inside or out. So that is chloride ion is more related to the inhibitory effect. So okay, transmission. And now, so pain modulation. So already I told you two parts I have told you. Now pain modulation. So I'm telling you that pain modulation, already I told anatomically it starts from the periaqueductal gray matter, and this is the area. From there it starts, descending pathway starts from this periaqueductal gray matter area, and this periaqueductal gray matter area, descending pathway starts, and ultimately it affects at the dorsal horn level. Where it affects, uh, it is at the dorsal horn level. It decreases the, tries to dampen the pain. Okay. Okay, now this is the as I told you, it stopped, I don't know. Anyway, so pain modulation, as I told you that in pain modulation, descending pathway takes the main important thing. So it starts at the periaqueductal gray matter, and it, as I told you, so this picture you have seen in anatomy part. So when periaqueductal gray matter is stimulated, along with this nucleus raphe magnus and locus coeruleus, all these areas are responsible for the descending inhibitory tract to function. Okay, so descending inhibitory system, periaqueductal gray matter, reticular formation, nucleus raphe magnus. So from there, the fibers come and act in the dorsal horn level. They work through adrenergic and serotonergic and opioid receptor mechanisms by these two mechanisms. So just remember this name, that one is opioid receptor mechanism and one is adrenergic serotonergic mechanism. These two mechanisms are important for descending for inhibitory system to work. Something has happened. Anyway. Okay. So okay, so this modulation part, as I'm telling you, that since we are talking about the good pain, as I told you that this, I am clearly audible, no?
Yes, sir.
Hello.
Yes,
Yes,
clearly
sir.
audible.
Okay. I don't know,
Sure.
some video has
Everything
stopped
is
actually.
good.
Okay. Okay. So till now, modulation. So modulation part also I have told. Just a minute. Okay. So descending inhibitory system already I told. Then comes modulation part. So descending inhibitory system is a part of modulation. Okay. So as we are talking about the good pain, so we will see up to this much. Okay. So what is that? That in normal condition it causes, modulation means inhibition of pain signal transmission. Okay. So our body wants that whenever first order neuron brings some impulses, second order neuron should get some less input, so that ultimately the perception will be less. So that is called inhibitory modulation. Now inhibitory modulation is by the supraspinal inhibition. It has two parts. One is supraspinal and one is segmental inhibition. Supraspinal inhibition, as I told you, that is starting from the periaqueductal gray matter, and from there the fibers which are causing the supraspinal inhibition, that is called descending inhibitory tract. And they work through opioid receptor and serotonergic receptor. Now this is already I have talked about supraspinal inhibition. Now there is another inhibition which is working, that is segmental inhibition. Now this segmental inhibition doesn't work just like that automatically. Either it can be activated. So what it causes actually in segmental inhibition? So it takes the help of gate control theory, and all pain at different side, that is not important. So gate control theory, it works through gate control theory. It can be activated. So they work through glycine and GABA receptor. Just remember this, that they work through glycine and GABA receptor. And okay, so what is gate control theory? I told that it is not that automatically it is working. It has to be activated. So how do you activate? Say you have a there is a injection. After giving injection to a child, you must have seen that nurses, they will rub that area. They will rub the area of the injection. So what actually they are doing? They are doing they are actually stimulating the A beta fiber. They are stimulating the A beta fiber. That is this fiber. Okay, which is sensing the okay, this is anyway. So A beta fiber is being stimulated. So A beta fiber, what it transmits? A beta fiber, as when I was showing you, I showed you that A beta fiber is bigger than A delta fiber. So when you are rubbing in that area, so and when there is a stimulation of A beta fiber, then pain fibers, let is A delta fiber, does not does not pass the gate, means it doesn't cross the dorsal horn area, and thus second order neuron do not get the chance to get stimulated by pain. Here, say this is the A beta fiber and this is the A delta fiber. This is the A delta fiber. So this is pain sensation and this is vibration sensation. Okay. If both the fibers, they has to come through this dorsal horn, and this is the second order neuron. This is the second order neuron. If both are stimulated together, then only this side A beta fiber can send their impulses, but not the A delta fiber. Okay, that is called gate control theory. So either we can stimulate by this type of rubbing and all. There are some many other like TENS and all. So these are all working in this gate control theory. Somehow, some way, if you stimulate the A beta fiber, then it will stop the A delta fiber action. Okay, so that is also a part of segmental inhibition. So that is also a part of segmental inhibition. Okay, so I understood that in normal body there is inhibitory modulation working, and inhibitory modulation always supraspinal inhibition is normally working. You can start or activate the segmental inhibition. So that is also, you can start different way, and even you can use it as a treatment purpose, by different neuromodulation techniques. Okay, like say TENS is also a treatment for treatment purpose you are doing. But in many areas, when we are stimulating the A beta fiber, A delta fiber cannot send the pain impulses to brain. Lastly, this is the perception part. So perception is reality. We know that we can see that it is when we think that this person should die in this low temperature, but he is sitting here. So here in perception area, it is not the somatosensory effect which is ultimately felt by the patient. It is the somatosensory effect and emotional part also. So perception means it is the addition of sensory discriminative and emotional affective or affective motivational part of the brain. These two effects together, that will be considered as the perception of the patient. Okay, so one person is playing football, and if he suddenly during playing he may break his ankle, or still he is going on and running, and then after few minutes he may feel the pain. So that is due to his emotional affective behavior, affective effect or affective motivational effect. He did not feel the sensory discriminative part. So that is what I'm saying, that is the additional effect. The total effect is called the uh, perception part. Okay, now let us talk about the complicated pain. Earlier we talked about good pain. Now we will talk about complicated pain, or bad pain, or neuropathic pain, or pathological pain, or scientifically, what should I say, that is the neuropathic pain. Okay, so what is neuropathic pain? When you have to understand the neuropathic pain, then you have to understand what is neuropathy first. Okay, so remember, this concept is very important, because many times those who are not in pain, not practicing pain, or not much concerned about pain, they may tell you that just by painkiller you can cure a pain of a person. So what is the need of this big reading and all? So understand this part, that every pain is not relieved by a tablet. So what is neuropathic pain? So what is neuropathy first? So you see, so this is a battery. Okay, this is a battery and this is a bulb. So when current is produced from here, so current is going from this side, and ultimately bulb is glowing. And so what is the action of this wire? This wire action is nothing but the transmission of the electricity. It is not doing any other thing. It is just transmitting. So now, can you imagine such a condition when there is no battery, but this wire is starting and transmitting electricity? This wire has become charged, and it is ultimately sending the electricity, and bulb is glowing without the battery. So can you think of this type of phenomena? So if you cannot think, that is in normal life we cannot think, but if you consider that this bulb, this battery part is, say, action potential started at the nociceptor level, okay, nociceptor level, and then these are nerves for transmission, and this area is our brain, okay, brain which is perceiving the pain. So this can happen that this area, nociceptor area, peripheral area, has become healed, completely healed. There is no more transmission, either completely healed or partially healed, but these nerves, they are starting the action potential now. So if, say just for an example, here action potential 40 is being produced. And earlier this nerve doesn't add anything, and here in brain also 40 action potential takes its effect, okay, we get that much pain. But after few months, this nerve starts producing 20 action potential from its own capability. So ultimately here it will become 60 in place of 40. So so this doesn't matter that after few days it becomes 40 itself, and that this area is completely healed, but still I am having a pain produced by 40 action potential. So this is just an example. So this is called neuropathy, a disturbance of function or pathological change in the nerve. Nerve is not only transmitting, it is producing action potential. Neuropathic pain, pain caused by lesion or disease of the somatosensory nervous system. So here also central neuropathic pain, peripheral neuropathic pain. So peripheral somatosensory nervous system means up to the spinal cord and up to the dorsal horn, say, and from dorsal horn to above everything is central neuropathic pain. Why I am saying central and peripheral? Nerve can be damaged in throughout its length, in first order neuron also, second order neuron also, third order neuron also, anywhere there can be a neuropathy. So if the neuropathy, that this thing what I have just told you, that neuropathy means it starts its own action potential. So if this is produced by second order and third order, then it is central neuropathic pain. If this is produced by peripheral first order neuron, then it is peripheral neuropathic pain. Okay, this is for classification or understanding purpose. Recent classification change, there is a nociplastic pain. So this is not that important, but you should know like neuropathic pain when we are saying, so many things are clinically detected. In every time it is not well detected by any machine. Okay, so if you can find, you can identify that, okay, this specific nerve is causing the pain, then we will say it is a neuropathic pain. And if it is only detected by the type of pain, that there is patient has a neuropathic pain, but you cannot target a specific nerve, say fibromyalgia, or say like many other diseases. So in those cases you will say this is nociplastic pain. So this is just for research purposes, you can say this type of classification. Otherwise nociplastic pain is also a type of neuropathic pain only thing is that which nerve we do not know. So this is recent new classification. How do we identify? So if we cannot prove it by any uh, uh, normal lab test or anything, we cannot prove. So how do we identify? One symptom is hyperalgesia. Hyperalgesia, you already know that which should cause mild pain, it is causing too much pain. Then allodynia, which should not cause pain, that is also causing too much pain. So that is hyperalgesia and allodynia. These two things are mainly clinically used for detecting a case of neuropathic pain. Pathophysiology. Why this happens, neuropathic pain? So one word, it is called sensitization. Okay, what is sensitization? That is a so different small definitions are there. Sensitization has been subdivided by multiple small phenomena. So these are the names: summation, wind up, after discharge, or long-term potentiation. So these are there. So ultimately what happens, as I told you, that decrease in threshold, increase in frequency response, as I told you, that nerve has become problematic. now nerve is starting its own potential, or it is helping to produce more action potential than it should have been. In a normal case, when the first order neuron brings 20, it should have produced, it should have transferred 20 to the third order neuron, or say up to the cortex, but it is giving its own contribution. So that is what here it is written, like decrease in threshold, like when the first order neuron should be able to fire in the second order neuron, if the threshold decreases, then more second order neuron uh, will be carrying the action potential, or at the nociceptor level also this is the same phenomena. So ultimately these are the things happens, and as I told you, these together everything, the phenomena is called sensitization. Okay, sensitization is the backbone of neuropathic pain. Here also peripheral sensitization, central sensitization. You understand that which one is peripheral, means first order neuron, the neuropathic pain starts, then it is peripheral sensitization. If second order, third order neuron neuropathy has occurred and neuropathic pain starts, then it is central sensitization. So now let us see this picture again. So as I told you, till now we have talked about good pain. Now as I told you that neuropathic pain or bad pain, when neuropathy occurs, so now we can understand that modulation doesn't mean only inhibition. So this is the normal time when the modulation is this inhibition is occurring. But in a disease state, when patient is in a chronic pain for a long time, then what happens? Then modulation also means facilitation. So peripheral modulation, central modulation means at the peripheral, at first order neuron, if the neuropathy has occurred, then we will say that peripheral modulation has occurred. Peripheral sensitization has occurred, of course, this is facilitation has occurred, or central modulation by central facilitation has occurred. So ultimately it is the sensitization, and small, as I told you that these are all wind up and all summation. So these are part of sensitization. So it modulation, two ways it can occur. It can so in modulation, two things can occur. It can inhibit also, it can facilitate also. In disease state, it will increase in modulation, facilitatory modulation we will say, and in normal state it is inhibitory modulation. Okay. Okay. So pain memory and cognitive modulation. So it involves patient's ability to relate a painful experience. So this is also, as we know already, that this stress increases the perception of pain. So this is also a part of modulation, when stress is increasing the patient's perception. Okay. So why this is important to know? Because this also has some treatment related application. Okay. So classification wise, there are so many classification. We know, like multiple classifications of opioids. So here also so many classifications, but only one important classification we must remember, that is nociceptive neuropathic. Nociplastic, as I told you, that this is also a type of neuropathic pain only when we do not know from which nerve is causing the pain. So nociceptive neuropathic is the most important classification, because it tells you a general approach to management, how we will treat that patient. Completely different treatment from for nociceptive pain and neuropathic pain. So nociceptive pain, already I told you, it is like directly related to the injury. So it is good pain, good for our body, we have to for our living. Neuropathic pain, it is a disease state and it doesn't have any good effect. Okay, so here you can see the differences. It is physiological pain, it is pathological pain, and symptom of disease is nociceptive, and it is a disease by itself when it is diseased nerve. Okay, and here simple relationship between pain and tissue damage in nociceptive pain, and here dissociated relationship between pain and tissue damage. Maybe there is no tissue damage or very less tissue damage, but pain may be very excruciating. So this is the biological function and our friend, and no biological function. So this is the difference. Pain side effects, there are so many side effects. So just for tell you, so sympathetic system, So in sympathetic system, already anatomically you understood that where the sympathetic system lies. So clinically, when I told you neuropathic pain, in neuropathic pain we understood by allodynia hyperalgesia mainly clinically. But neuropathic means nerve is damaged. Which nerve is damaged? It can be a somatosensory nerve. It can be a sympathetic nerve also. So if it is a sympathetic nerve, it is a visceral sympathetic nerve, then what you will see? Then you have to see allodynia. Allodynia hyperalgesia is common. Other than that, peripheral these are, everything will be there. It is not like that, but if few symptoms or signs are there, then you know this is a sympathetically mediated pain. Disproportionate pain to injury, that is common for all neuropathic pain. Peripheral pain that spreads centrally, so that is also possible. Contralateral side involvement. So this is remember, in our ophthalmology we have read about sympathetic ophthalmitis. So this is a characteristics of sympathetic system. One from one hand CRPS, patient develops another hand CRPS. So contralateral side involvement. Color changes. So sympathetic system will cause vasodilation or vasoconstriction in different situations. So color change will be there, either bluish or pinkish. Sweating in affected limbs. So that is also vascularity related. Cold periphery with vasoconstriction in affected limbs, or piloerection. So these, if anything is there with allodynia hyperalgesia, you know that this pain is sustained by sympathetic system. Okay, so then treatment will be a bit different. Now advanced understanding. I will not go into the detail of this advanced understanding, just to tell you that you just read in our study materials and all. So referred pain, there are multiple hypotheses. Phantom limb pain. What is important for phantom limb pain? In pain and nociception, I told you that nociception and pain are two different phenomena. Nociception means when nociceptors are activated. That means nociception has occurred. Transduction has occurred means nociception has occurred. Pain means when perception has occurred. Okay, so phantom pain means when there is no hand, patient is having hand pain. There is no leg, patient is having leg pain. That means there is no nociception, but there is pain. Okay, so this is the unique thing of this phantom limb pain. Can somebody tell about such a condition where there is nociception but there is no pain? It is just the opposite of phantom limb pain. Nociception is there but no pain. Anybody? Nobody? Okay. Cervical cord transaction. Cervical cord transaction, complete transaction, say patient is lying in ICU and you are doing one procedure in the periphery thinking that patient don't understand anything. So you are doing, you are cutting the skin without anesthetic. So what you are doing, you are giving the nociception. You are giving the pain, there will be nociception, there will be all autonomic sympathetic activity, but patient will not feel any pain. Okay, so this thing is possible. Psychosomatic pain, as soon as we understand that there is psychosomatic component, we do not treat, we send to psychiatrist. Placebo, nocebo, how it works. So that also you should you read from the book. I'm not going in detail of it. So thalamic pain, it is a specific type of pain. When neuropathic pain means neuropathy has occurred, but where? It is in the third order neuron. Okay, directly in the thalamus or above. Then this is called thalamic pain. So in stroke patient, most of the time we see that whole half body is paining, complete half body. So in thalamus it causes mainly. So that is a different type of pain. So just to but it is also a neuropathic pain. Okay. Okay. So now I will go to a bit of clinical part, then lastly pharmacology part. So should I ask some question? Anybody please tell me the four parts of the pain pathway. Let's see.
Transduction, transmission, modulation, and perception.
Okay, okay. What is the velocity of a delta fiber?
5 to 15.
Yeah, 5. Oh, very nice. I tell that, okay, remember 20 up to. It's okay. 5 to 15. Yes, yes. Meter per second. Meter per second. Okay.
Yeah.
Then descending inhibitory pathway starts from which area, anatomical area of the brain? Mainly.
PAG.
Periaqueductal matter.
Yes, periaqueductal gray matter. Okay, okay, okay. Then comes okay. So what is the main uh, phenomena which is responsible for neuropathic pain?
Sensitization.
Sensitization. Yes. You can remember all the subphenomena, but total, when this is the umbrella term, if you use, that is the sensitization. That's it. Okay. So let's start with the introduction of pain medicine. So this is a clinical part, I will say. So see the patient profile. Where from these patients are coming? These are not new patient. Our stream is, the subject is a bit newer compared to other subjects. So these are not new patient. So this we have in our subject, there is some overlapping area with orthopedics, physiotherapy, sports medicine, rheumatology, neurology. So this is the overlapping area. But in pain medicine, so what is our USP? Our USP is mainly the interventional part, interventional pain management, those small interventions, ultrasound guided or fluoro guided, that is the unique part. Otherwise, the treatment of conservative treatments given by all other specialties are same as we are giving. Sorry, actually I am having cough, so that's why. Anyway, so which are the mainly which are the patients we see actually? So mainly it is the chronic pain. Only all chronic pains you see. In acute pain, if it is acute on chronic, say one person has acute slip disc, but he has back pain for a long time. In that case, we will see. Otherwise, some specific acute pain like sprain. He was playing and having sprain. There is a tendon tear or anything like that. So in few scenarios, we also treat those patients. Post-operative pain is mostly seen by anesthesia people. So those who are practicing in OT, they will see post-operative pain. And in other acute pain, we won't see. Most of the time, we won't see. It does. If a person is coming with angina or say any other type of injury, then you should not see. That is not our subject. Okay. So first step, how do we see? How do we approach a pain patient? First step is make a diagnosis. So what is the, how do we make the diagnosis? So first answer to these three questions. Where is the pain coming from? That is called pain generator. What is the type of pain, nociceptive or neuropathic? And what is the pathophysiology? Remember, what is the, where is the pain coming from means pain generator means the, okay, let me tell from here. So pain generator, so these are the structures which can cause pain. So understand the pain generator, these structures are there in the patient's body since birth. It is not, it is not that some new structure has come. So why which structure is causing the pain? So that we want to know. So that is the pain generator. Even sometimes idiopathic also I have written as a cause, because we may not be able to know that which structure is causing the pain. Second, background phenomena. Since this is what I'm saying, that these structures were there in the body since birth, suddenly it is not it is has not come. So why it has become painful? So there must be some reason. It may be inflammatory reason, infective reason, degenerative reason, traumatic, malignancy, neurogenic, psychogenic, referred, vascular, idiopathic. Again, I have written idiopathic. Why? Sometimes it happens that we do not know the background phenomena also. We do not know the actual starting point or pain generator also. So this is possible. Most of the time when what we practice is the degenerative phenomena. Background phenomena is degenerative. Sometimes inflammatory arthritis also comes to us. So inflammatory phenomena also we will see. Infective we won't see, traumatic we won't see, malignancy we can see at the pain for pain relief purpose, but otherwise we will be the additional physician, but otherwise oncologist will be the primary physician for a malignancy case. Then neuropathic, of course, neurogenic pain, that we will of course see. Psychogenic we must take, if psychogenic pain we must refer to the psychiatry. Referred pain of course to the specific specialty. Vascular pain we may, uh, there may be a pain relief procedure indicated, but we are not the primary treatment specialty in a vascular case of pain. Idiopathic of course different. Red flags for pain physician: fracture, infection, malignancy, motor weakness. Remember this. This is a very important. This is a very important thing. So fracture, infection, malignancy, and motor weakness. Motor weakness or progressive neurological dysfunction. Some patient has come with a slip disc, but he cannot lift his leg also. Then we will not treat that patient. We will send to the surgeon for immediate treatment. Okay, and these cases are for red flag for pain physician. In history, when we are taking the history, we will always search for a hidden pattern, because if we start taking the full history for all patients, then it will, one patient will take at least 2 hours time. So we will ask the relevant questions, okay, whichever is important. So we will always try to find out the hidden pattern in patients complain. Okay, then obtaining a detailed history. So earlier all these parts are normal: present history, past history, family history, personal, drug, allergy. So all these things we should know, but specific pain history is important for us, that is not practiced in any other specialty. So specific pain history we will take, we will take this history in detail. Psychological assessment is also an additional part, okay, that is also very important. Specific pain history: location, radiation, type, intensity, onset, precipitating and relieving factor, and then just a minute. Precipitating and relieving factor, effect on daily function, and associated symptom. So these are specific pain histories. Okay, so everything has its own importance, like intensity, onset. So whenever indicated, and precipitating and relieving factor, so these have their own importance. While history taking, earlier we used to use these things a lot. Nowadays we do not use that much, but of course in a setting of research setting you can use these tools. So this is called pain diagram. When patients sitting in outside of your chamber, and patient has not entered your chamber, you are seeing another patient, then you can give the patient this pain diagram part. Patient can feel that where there is the patient is feeling the pain, in which area. Okay, and this pain diagram also have a good aspect, that sometimes patient fail to tell the specific symptoms when inside your chamber, so they can get more time for describing. Okay, so they can mark here, and symptom pattern, their symptom pattern, this is also wherever applicable patient will be marking this. Say this is applicable to a headache patient, not a arthritis patient, because this is a continuous pain. Okay, NRS, this is also, as I told, these are more important for research purposes nowadays. Otherwise we just ask mild, moderate, severe, how much pain you have. Now psychiatric evaluation is also very important. Many chronic pain patients they may be psychologically depressed or anxious if it is going on and on. And many neuropathic pain patients, as I told you, that say fibromyalgia, CRPS, those very a bit rare patients, but neuropathic pain, severe neuropathic pain patients, like say post-herpetic neuralgia, they are so much depressed they want to commit suicide many times. So in these cases, okay, this is not the questionnaire, this is the questionnaire. Depression, rule out depression. So PHQ-9 test, you just rule out depression by this type of questionnaire. So just if you see that okay, patient is depressed, you must send to the psychiatrist. And this questionnaire was actually to know whether the pain is neuropathic pain or not. So as I told you that we need to know that one patient is neuropathic or nociceptive for treatment purposes mainly. So these are symptoms and signs when we can say that okay, this patient is having a neuropathic type of pain. Okay. So associated symptoms also should be mentioned in all the cases. So when a patient of pain comes, it is not that nothing else will be there. So if there is a muscle spasm, that is also should be noted. There is a range of movement, I mean restriction of range of movement of say back or neck, that should be written. There can be vomiting tendency, there can be dizziness, or say some motor weakness. So all these things should be written. So now last part, we have understood that how, what we want to know from the patient. When we are seeing a patient, we want to make a diagnosis, and diagnosis by 3 questions. One question is where from patient pain is coming, that is pain generator. What is the background phenomena which is causing the pain, that is the uh, pain background phenomena. Okay, so this is the second pathophysiology. So this is the second question. Third question is symptomatically what type of pain patient is presenting with. So that is either nociceptive pain or neuropathic pain. That will dictate us the treatment part. So these 3 things we want to know from history, and we will make a diagnosis with these 3 questions. Okay, so okay, treatment. Okay, so treatment approach, as I told you. So treatment ultimately with these 3 questions, what we have gained, that is the diagnosis we have made. And now in treatment, either it is the symptomatic treatment or modifying the background cause. So either the pain generator part, which is causing the pain, either you treat only that part, pain generator part, or you modify the background cause. Say it is a degenerative case, so there is nothing to modify in a background cause, but it is an inflammatory case. Then say it is an inflammatory arthritis, then you have to give treatment for inflammation also. But if it is a degenerative case, then only the symptom management is the sufficient treatment. Okay, so in pain clinic, a majority of patients are coming who have the pain generator. We find it the pain generator, mostly the background cause is degenerative. Okay, now symptom pain management at the pain generator. So remember, so think that background phenomena is degenerative, so our treatment will be concentrated for pain generated treatment. So first thing, multimodal multidisciplinary is the principle of treatment of pain physicians. Okay, multidisciplinary and multimodal. So you can see tablet is there, some intervention is there, and so different type of treatment is there. And then some these are insoles, shoe insoles. So these things are also practiced. So this is a physiotherapist, maybe occupational therapist, psychiatrist. So these are multidisciplinary inputs are there for getting the maximum benefit for the patient. Okay, so this is the first thing. Second thing, so let us talk about the pharmacotherapy part. Just a minute. Okay. So let us talk about the pharmacotherapy part. So remember, in the physiology part, transduction, transmission, modulation, perception, all these 4 areas are there. So when we will write the drugs, write the medicines, we will think that where actually we are targeting. We can target transduction area also, transmission area also, modulation also, or perception area also. Transduction area, when the inflammatory these cytokines have been secreted, and ultimately the action potential will start. So there prostaglandin pathway is the most important pathway, okay, through which prostaglandins are formed. You can see phospholipase A2 comes from the cell membrane, then it forms the arachidonic acid. From arachidonic acid prostaglandins are formed, and these prostaglandins are actually there are two types of prostaglandin, okay. Prostaglandins formed by two types of enzymes. One is cyclooxygenase 1, one is cyclooxygenase 2. When there is a disease state, there is a heart, there is a injury, then this COX2 means cyclooxygenase 2 is formed, and they form a separate group of prostaglandin, and these have all this doesn't have any good function, beneficial function to the body. These have the this is for pain, this produces the pain, okay, these prostaglandins. So if we can stop the COX2 here, then these prostaglandins will not be formed. So mainly the COX2 we want to block. But of course, if you have selective COX2 blocker, then you will block here like cyclooxygenase 2. If you use non-selective COX2 blocker, then you will block here COX1. Even steroid someone can use to block the phospholipase A2 here, so that the arachidonic acid itself is not formed. So ultimately in transduction area, prostaglandin pathway is targeted by these two drugs, NSAID and steroid, so that patient doesn't feel pain. In transmission area, I already told you that three things are important. One is your neurotransmitter, one is receptor, and one is ion channel. Okay, so there is no drug specifically for these neurotransmitters, okay. It is there, but it is all experimental basis. These are not marketed like that. So these neurotransmitter and anti-neurotransmitter we don't have, so it is a anti-receptor. We can go for anti-receptor, and so our drugs will mainly act as on the receptor, and also at the ion channel, like as I told you, ion channel mainly in the sodium channel or calcium channel. So you can use sodium channel blocker, calcium channel blocker, like that. So our drugs here, you can see most of the this part you should remember, that NMDA, AMPA, these receptors, or NK1, these receptors are have an excitatory effect. So in this case, excitatory means it stimulates the pain propagation, pain impulse propagation. So if you use some drug against these receptors, they will be of beneficial, give beneficial effect in that pain patient, okay. And these substance P, CGRP, aspartate, ATP, glutamate, these are for, these also have excitatory effect. These are neurotransmitters. Then what are the inhibitory neurotransmitters? So these neurotransmitters are from here, opioid, enkephalin, beta endorphin. These are main opioid inhibitory neurotransmitter. Then GABA glycine is there, and serotonin and norepinephrine are very important. Serotonin, norepinephrine. So these you should just remember, mainly enkephalin, beta endorphin, norepinephrine, serotonin, and GABA glycine. These six you remember, okay, and they act on these opioid receptor or serotonin receptor or GABA receptor. And when they act on these things, these receptors, they produce the inhibitory effect. So what we should do, either we increase the power of these inhibitory system, or we antagonize the excitatory system, okay. So this is the summary actually how it works. Then ultimately it is the receptor blocker, means here it works at the NMDA receptor blocker or AMP receptor blocker. So mainly our drugs act as at the receptor or at the ion channel. Okay, so what are the drugs? Local anesthetic, anti-epileptic, paracetamol, these are the drugs. Okay, so we can see so many receptors are there, 5-HT receptor, NMD receptor, glutamate, but you will see that all the receptors, ultimately the ions are either calcium or sodium. So calcium channel blocker, if you use, then ultimately it is going to block every receptor. Okay, so these ion ultimately the ion channels are same. Okay, so these drugs are used in this way. So here you can see in inhibitory this I mean inhibitory system. In modulation already I showed you this inhibitory system. So in supraspinal inhibition, descending inhibitory tract, they work through opioid system and serotonergic or noradrenergic system actually. So opioid system and serotonergic noradrenergic receptors, these receptors through. So you can understand that when we give a drug which act through these receptors, serotonergic, adrenergic or opioid receptor, means agonist you are giving, then we are actually increasing the power of descending inhibitory tracts. Okay, and if we giving some GABA activator, then we are actually using the power of gate control, means this one glycine, GABA glycine here in the for segmental inhibition. So here these drugs work here in this inhibitory function, they increase. And when we use the anti-epileptics or other neuropathic pain drugs, then where we target the sensitization. This sensitization we are targeting by different anti-epileptic or tricyclic antidepressant drugs. Okay, perception area, emotional affective area. If you mainly as we told that sensory discriminative and emotional affective. So sensory discriminative you hardly can do anything in perception, but emotional affective area, when you know that depression or anxiety is increasing the pain perception, then you can send to psychiatry and they may go for CBT, cognitive behavioral therapy. So this part can be taken care. So a single drug can act at multiple sites. When you are writing a drug, you must think that, okay, where it is working. Many times, if it is severe pain, we will write paracetamol also, we will write NSAID also, and then we will give some, say, opioid also, or some other drugs, gabapentin, pregabalin, like those things. So first we should think that either it is a neuropathic pain or nociceptive pain, then treatment starts accordingly. Then comes that these medicines where they are working. So a single drug can act at multiple sites, but the opposite is not true. Okay, multiple drugs, if they work at the single site, then your prescription is wrong. You are giving say multiple drugs which are acting on calcium channel. You are giving some gabapentin also, you are giving some pregabalin also, and all are working at calcium channels. Then what will happen? Calcium channels are already blocked. You are only increasing the side effect is not increased. So while writing the prescription, you write logically that we want more, a single drug should act at multiple sites, or it may be multiple drugs but at multiple sites. So that is called multidisciplinary, that we achieve by multi-model treatment. Okay, we do intervention also, we do tablet also we are giving. So different treatments, why we do it? For multi-model treatment, they work at different sites. Okay, so that is the thing. So you understood that while writing, we will think that whether it is working at transduction area or transmission area, like that. So transduction area target the inflammatory soup by interrupting the prostaglandin pathway. Transmission area either target the receptors NMDA, opioid, GABA, 5-HT. All are not agonist or antagonist. I mean, as you already know that inhibitory effect, so we will give the agonist, and excitatory effect we will give the antagonist. Ion channels, sodium or calcium. So either in transmission area you can give drug which works here. Then comes modulation, so target receptors. Again, in modulation part also, as already you understood that descending inhibitory system works through norepinephrine and serotonin, 5-HT and norepinephrine, and through opioid. Also, it has some effect through opioid NMDA receptor. Perception you can target by CBT. So, and placebo non-radiation traditional act at modulation. This is I have written just that in many different other non-traditional these are their treatments. They mainly affect at the modulation or perception part. They say simple your message. Somebody is getting body massage, then what he is doing actually? So body massage is if there is muscle spasm, that is different, but otherwise body massage, why, or oil massage, why patient is getting better relief, because they are stimulating the A beta fibers, and then A delta fiber is not transmitting the pain. So ultimately it is the modulation part. Okay. Or of course the perception part area also, sometimes patient feeling good, that's why also patient can perceive less pain less. Okay. So clinical approach: first step medicine, second step intervention, third step surgery. In this way we in general approach a patient. Other disciplines and other input from other discipline is, if it is needed, then it will be required at every step, any step. So if the patient has a depression or anxiety problem, then it is not that when we will do intervention then we will send the patient, we will send from the first step. So here remember this part. So as I told you, medicine is similar, like everyone whatever it is advised. So intervention is our USP. So why do we use intervention? Huh? So intervention, as I told you, patients when they are coming, we have already taken the history and we have understood that from where the patient is coming, pain is coming, that is pain generator, and uh, why the pain is getting formed, background phenomena is probably degenerative. Then if it is degenerative, then only pain generator treatment is there. So intervention is mainly always, most of the time, it is targeted to the pain generator, not for the background phenomena. So pain generator, what we can do, say one joint is causing pain, either you take care of local inflammation, either the joint is inflamed, so either you can take care of local inflammation, or you regenerate the structure. Try regenerative therapy. I mean, in joint or tendon, whatever, try to regenerate the structure. Or third one is, there is no inflammation, there is no question of regeneration, it is damaged completely. Target the nerve supply. Then that nerve which is causing the pain from there, if you destroy that nerve, then patient's pain can go. Of course, you cannot ablate a motor nerve. It has to be sensory nerve. Okay. Now, nerve supply, either it can be ablation or it can be a modulation also. Modulation, when it will work, as we have told you in physiology, that it can be, there can be a gate control theory. We can activate the gate control theory. Okay. So if we can do something where A beta fiber is multiple times stimulated, then A delta fiber will not be able to produce pain. So take care of local inflammation by steroid. So remember, these are all treatment of pain generator. Regenerate the structure by PRP, dextrose, ozone. These are called prolotherapy, proliferative therapy, regenerative therapy. Of course, many different specialties, they have given multiple different names. Orthobiologics or regenerative prolotherapy, all are same actually. So regenerate the structure and target the nerve supply, either ablation or modulation. You can do ablate by heat or cold, both radio frequency by heat, cryo by cold. Though by cryo it is not complete ablation, um, it is second degree ablation, so second degree nerve injury, like but then you can think that it is a part of ablation, RF and cryo. and chemical ablation, chemical by phenol or alcohol. Glycerol and all are there, many things are there, but we do not use much. So these are chemical ablation can be done. Neuromodulation, as I told, neuromodulation techniques are there, different neuromodulation techniques are there. It starts from brain to periphery, and like say TENS is a very peripheral neuromodulator. Okay, neuromodulation you are doing, so that is also a part of treatment. Okay, so this is the summary of intervention. Thank you. I think is there any question? Anybody wants to ask anything? Anybody want to ask anything? So these okay, so anybody have any question? So we will actually post the ultrasound, basics of ultrasound. We will post the video, because in one day so many topics cannot be taken. But of course, you see the videos, because later we will start showing the ultrasound. First basic part you must know. So those recorded videos you please see. Radio frequency also we will put the recorded video. Please see the radio frequency, how it works. I told up to the neuroablation part, that approach of all treatment, but how it is done, radio frequency, you see the video. Okay. So any question? No question. Okay then. Devjyoti?
Yes, I think we can finish today. And please
Okay.
check the study materials and the other things, they will be there.
Hmm.
Okay.
Okay then. Thank you. Good
I'm
night.
requesting everybody to appear in the test.
Okay. Good night. Somebody can speak. Think.
Yes, sir. Good night.
Yes, sir. Good night.
Thank you, sir. Good
Thank
night.
you.
I become
Sir,
confused.
actually, I have a doubt regarding sensitization, the central and peripheral sensitization. That,
See,
yeah, yeah.
central and peripheral, there is no, I mean, nothing big to understand. If the sensitization is occurring in the first order neuron, that is peripheral. If it is second order or
No,
third order neuron, that is central. Tell me.
no, the purpose of the main role of sensitization in our body. What is the physiological role for?
No physiological role. That is, the sensitization is producing neuropathy. Neuropathy is producing neuropathic pain. Neuropathic pain is a bad pain and do
Sense.
not have
Yes, sir. Yes,
sensitive.
sir.
Sensitization is the background phenomena. Background phenomena is sensitization, and it is ultimately causing neuropathic pain. Neuropathic pain doesn't have any good relation, good effect. Okay, that we want to get rid of neuropathic pain, so that doesn't have any good effect. And sensitization is the what should I say? It is one umbrella term for all types of pathophysiology, that how the neuropathy occurs. That's it.
Okay. Okay, sir.
Yeah. So you see the video. You see the video. I have sent the study material also. So after that also, you have, if you have confusion, you tell me. Okay.
Okay, sir. Okay, sir. Thank you.
Yeah. Yeah. Okay. Okay then. Thank you. Good night.
Thank you,
Okay,
sir.
thank you.